So without further ado, Community College Oncology with Chaely Medley, RN, MSN, AGNP-C, caring for patients with lung cancer. Chaely, welcome. So glad to have you here today.
Thanks for having me.
Absolutely. So let's find out a little bit more about you. RN, MSN, AGNP-C works with the UNC Thoracic Oncology, and you help patients on both standard of care therapies and clinical trials. In 2019, graduated from the University of North Carolina at Chapel Hill, great institution, and with an MS in nursing, studying adult gerontology primary care with a focus on oncology. In 2023, included in 2 abstracts presented to ASCO Quality Care Symposium and ultimately published in the Journal of Clinical Oncology. Congratulations.
Thank you.
And a favorite aspect of medical oncology is building relationships and shared experiences with patients and their families, and teaching and engaging others in the importance of informed quality patient care is an honor.
It is.
Great. Well, that hopefully lets our audience know a little bit more about you. What about outside of your professional life? Any particular things we should know?
I have 3 kids and
Wow.
2 German Shepherds.
Wow.
And so they keep my husband and I very busy.
I'll bet.
And
I'll
so
bet.
we like to do lots of fun things. We day trip. We just went yesterday to the mountains to go tubing.
Great.
For my son's
Great.
3rd birthday.
Oh, that sounds
so
like a blast.
We try to get out as much as we can.
Good for you. Good for you. All right. Well, caring for patients with lung cancer, I'll turn the controls over to you.
So thank you for joining me. We're going to be talking about caring for patients with lung cancer. So our learning objectives for this lecture are to identify common causes and symptoms of lung cancer. We're going to discuss the diagnostic process for lung cancer, including next generation sequencing, which is really important. We'll describe the lung cancer staging and classification system, and then we're going to recall treatment options that are available to these patients and the most common adverse effects of these therapies. So first, what is lung cancer? Everybody, I think, hears a lot about lung cancer. It's very, very common. Most people at least know somebody that has been affected by it, and so I want us to have a good understanding of what it actually is. So lung cancer occurs when cells originating in the lungs begin to grow out of control. It can begin in the lungs, but it has the ability to metastasize to other areas in the body, and the most common sites of metastasis are the brain, bone, liver, and lymph nodes. Also, the adrenal glands are commonly metastatic sites. Lung cancer is the leading cause of cancer death in the U.S. So a lot of times people will say, oh, they have lung cancer and brain cancer, but oftentimes they just mean that they have lung cancer that's moved to the brain. In 2023, lung cancer accounted for 12.2%, so that's 238,340 new cases of all new cancer cases, and accounted for 20.8% of all cancer deaths. So those are significant numbers. And this little graph here on the bottom is just showing that from 1992 to 2020, so about 30 years, the rate of cases and the death rate have declined over time. Now, whether this is certainly from decreases in causes of smoking or causes of lung cancer, but also in new advances in cancer care that we're finding every day. So who gets lung cancer? Lung cancer is the leading cause of cancer death overall and among both men and women. The second leading cause of cancer death is prostate for men and breast cancer for women. It's more common in men than it is for women, and among men, it's most common in African American men, and for women, it's most common in non-Hispanic white females. The common age that people are diagnosed is age 65 to 74, with the median age being 71. This is a good image that's just showing 5-year relative survival rate by the type of cancer, lung cancer, at the stage of diagnosis. So we'll go into a little bit more detail moving forward, but there's essentially 2 main subsets of lung cancer. So for small cell lung cancer, there's about 30% 5-year survival rate for localized versus a 2 to 3% survival rate at 5 years for distant metastases. And I won't kind of go into all the others, but it's just a good breakdown that kind of demonstrates how the more it's spread at the time of diagnosis is really going to impact the 5-year survival rate for patients. Risk factors for lung cancer. Smoking is probably the most commonly known, and it is the most significant risk factor for lung cancer. It's known as a modifiable risk factor, which means that we can change this risk factor by not smoking. However, secondary to that, something that's maybe not so modifiable is secondhand smoke exposure. Usually people don't have much control over whether or not they're exposed to others smoking. Approximately 80% of lung cancer deaths in the U.S. are related to smoking. The way that we calculate the number of packs or a patient's smoking history and how significant this is in their diagnosis is by taking the number of packs per day times the number of years. So a patient that has a 40 pack per year smoking history, they could have smoked 2 packs per day for 20 years. Alternatively, that might mean 1 pack per day for 40 years. But this becomes significant when we're talking about a patient's age. So if a patient is 50 years old and they have a 40-pack year smoking history, that means they have a very, very heavy smoking history, and they're more likely to have lung cancers that are associated directly with smoking. Other risk factors for lung cancer, secondhand smoke exposure, as we mentioned. Radon gas exposure is the second most common risk factor for lung cancer after smoking. And then other chemical exposures, such as asbestos, when we're talking about mesothelioma. We don't really get into that today, but you probably see it on commercials. Arsenic, diesel exhaust, silica, and chromium. So again, there's 2 main types of lung cancer. The most common one is non-small cell lung cancer, and this accounts for about 85% of all lung cancers. Underneath that, there's 2 types, non-squamous and squamous. There's non-squamous, non-small cell lung cancer, and this is significantly adenocarcinoma, and this is going to be when mucus cells are mutated, and this is going to occur in outer parts of the lung. A squamous non-small cell lung cancer occurs when the squamous cells are mutating, and these squamous cells are flat cells lining the inside of the airways, and this is typically smoking related. The other type of lung cancer that we'll talk about is small cell lung cancer, and this occurs in about 10 to 15% of all lung cancers. This type of cancer is most commonly found in the central part of the chest, and it's known as being very aggressive and having poor survival rates. So signs and symptoms of lung cancer, most of them are related to breathing, of course. So cough, especially one that changes over time or becomes productive. Unilateral wheezing, and this unilateral is going to mean one side, and wheezing is kind of the sound that you would most commonly associate with asthma, and this is when airways are squeezed, though you can kind of hear the air moving in and out, and it sounds strained. Dyspnea, also known as shortness of breath. Pneumonia, patients that have frequent pneumonias or persistent pneumonias will sometimes go on to be diagnosed with lung cancer after they've gone through several rounds of antibiotics. Chest pain or pain in the shoulder and the arm, hemoptysis, which means coughing up blood or rust-colored sputum, vocal cord paralysis, and that occurs when there's tumors that are pushing on the vocal cords and it's causing hoarseness. Atelectasis, which is fluid buildup in the bases of the lungs, neurologic changes, so changes to their mental status, lethargy, feeling tired or weak, and unexplained weight loss. Those are more directly related to the lung cancer, but other things that can happen are bone pain when patients have metastasis to the bone. They might have nervous system changes where they have headaches, dizziness, weakness, numbness, and that's related to when they have cancer in the brain or in their spinal cord. Lymphadenopathy is swelling of the lymph nodes. This can occur outside of having cancer inside the lymph nodes, but commonly this is what it means. Jaundice, which is yellowing of the skin or eyes, and this is when the liver is affected by the lung cancer. Superior vena cava syndrome is where the tumor is actually pressing on the superior vena cava, and it's causing backflow of blood and fluid into the patient's face and neck. And this commonly occurs with small cell lung cancer. Other paraneoplastic syndromes like syndrome of inappropriate antidiuretic hormone, Cushing syndrome, and something called LEMS, Lambert-Eaton myasthenic syndrome. These are basically syndromes that have their own medical meaning, but in regards to the cancer, they are directly being caused by the cancer. So you can have a Cushing syndrome that's being caused by the tumor itself as opposed to the patient's pituitary gland. And then, of course, blood clots. Patients that have lung cancer are at a hypercoagulable state. So, quick knowledge check. Which of the following are risk factors for lung cancer? Select all that apply. Exposure to tobacco smoke, either smoking or secondhand, exposure to radon gas, exposure to certain chemicals, or exposure to chocolate. So the answer would be exposure to tobacco smoke, radon gas, and certain chemicals. Thankfully, not chocolate. And so how do we find lung cancer? Oop. There we go. So the first thing that we can do is screening. The American Cancer Society recommends yearly screening for lung cancer with the low-dose CT scan, and this is going to be for patients aged 50 to 80 years who currently smoke or used to smoke and have at least a 20-pack per year smoking history. The CT scanner uses cross-sectional soft tissue imaging to analyze the tissue for density, and it reveals tumors or displaced organs. And so the way I usually describe it to patients is that you lay on the table and the scanner kind of takes images that kind of cut like this, and then it puts them all together, and it shows where there are changes in the lungs that shouldn't be there. There's lots of things that you can see with the CT scan, but this is one of the first steps to finding whether or not there's tumors in the lung. So in terms of diagnosis, chest x-rays are usually the first test that we use to diagnose a lung mass. Outside of patients that are being screened because they have a smoking history and we're looking for cancer, trying to be proactive, oftentimes patients will present with symptoms like we discussed. They'll go to their primary care doctor, and this doctor will order a chest x-ray. On that x-ray, they'll see a mass, which could mean lots of things, but in order to actually narrow in on what it could be, the next step would be to get a CT. So they get a CT scan, which shows more detailed images of what that could be. Depending on the size of it, this might be something that's monitored maybe every 3 months with repeat CT scans, or they'll say this is very concerning for lung cancer because of the way it looks specifically. We would say if a mass is spiculated, then it's high probability that it's a lung cancer. And so from there, they're often referred to a medical oncologist, or they're being worked up with their pulmonologist, and a PET CT scan will be ordered. This is done most often after it's diagnosed, and we're going to be looking to see where else there could be cancer manifested in the body. From there, oftentimes brain MRI is used to determine whether or not lung cancer has metastasized to the brain. So that's generally considered to be like a full staging workup, is to have a PET CT and a brain MRI. So just a couple images to share with you. Over here on the left, this is a brain MRI that has a large tumor, and that bright stuff around it is some edema. The tumor itself is a pretty good size, but the edema that's surrounding it also causes significant symptoms. So this might be somebody who's having dizziness, headaches, maybe some mental status changes, things like that. On the right side, this top middle is a CT scan, and the bottom middle is a PET scan. And so just briefly, the way that PET scans work is by giving the patients a dye, and this dye is taken up by any tissues in the body that are metabolically active. So we know that cancer is very metabolically active, and it will suck up this dye and it will glow really, really bright. There are other parts in the body that are metabolically active, like the brain, uterus, ovaries, things like that, thyroid. And so we can have kind of false uptake, and it's good to know where you can have this false uptake. But we use the CT scan and the PET scan overlay to determine what these nodules are in the lungs that we see. You can see this mass over here on the right side of the lung. And then if you overlay it on the PET scan, you can see it's glowing really bright. So we can say that that's lung cancer. So after we have the images, the next step is to get tissue. So we have a saying in oncology that tumor is the rumor and tissue is the issue. And so there's a few options of ways that we can get this tissue, but without having the tissue, we can't say with 100% certainty, yes, this is a lung cancer, because as much as lung cancer can metastasize elsewhere, there are other cancers that can metastasize to the lungs. So oftentimes we'll refer patients to a team called interventional pulmonology, and the patient will undergo a test called a bronchoscopy. And this is where they'll use a thin tube with a camera at the end, and they pass it through the mouth to visualize the sample, and they'll take a little sample of it, and then we send that off for testing. A thoracoscopy is when we use a similar tube, but instead of going through the mouth or the nose, we're going to go in the side of the chest. Mediastinoscopy is where we basically we have a phrase we say staging the mediastinum, and when there's lymph nodes and things that we can see on the CT scan that are lighting up on the PET, then we can go in and take samples of that lymph node, and that's helpful because it will tell us whether there's cancer there or not. Sometimes you can have reactive lymph nodes that don't have cancer cells, and then other times you have cancer cells in those lymph nodes. And the number of lymph nodes and the location of those lymph nodes is important because you might only have a tumor in the lungs, but if you've had cancer that's spread to the lymph nodes that are found in the mediastinum, then it would upstage the patient's cancer. Other things we can do are the percutaneous needle biopsy. This can be CT or ultrasound guided, and this is when tissues aren't central enough to undergo sampling with a bronchoscopy. Also when patients have liver metastases or something like that that might be more easily accessed. Say we have good reason to believe this is a lung cancer with liver metastases, and that's easier to get to than the patient undergoing a bronchoscopy, then we can do a CT guided biopsy. This image here is showing the different stages of lung cancer. For non-small cell and small cell, they're staged a little bit differently. So for non-small cell, we're going to use the TNM system, and classically this is stages 0 to 4. But of those stages, there's a couple different subsets, and the subsets kind of give us an idea of how severe the cancer is and also dictate what kind of treatment the patient can receive. So the T is referring to features of the primary tumor, such as the size and its invasiveness. The N is referring to metastasis to regional lymph nodes. So again, that's how we're using the mediastinoscopy, is to look at those lymph nodes. And then the M is the presence or absence of distant metastases. So generally speaking, if it's left the lungs and it's in any other organs, whether it's the brain, the liver, bones, adrenal glands, or even the pleural space, it's considered to be a metastatic cancer. And that would be stage 4. Anything stage 3 and above, you can see there 3C and or below rather, would be something that we would hopefully be able to cure, and that's our goal in our treatments for our patients. For small cell lung cancer, we do use the TNM staging system when we're referring to the whole cancer will be staged on the TNM system, and that's a very specific way of staging. But in general, we're staging it limited versus extensive. We'll go into more of the differences of the cancers, but in general, we're thinking for limited stage small cell lung cancer, we want to be able to get this in one radiation field. And so the tumor is confined to one hemithorax and regional lymph nodes, whereas extensive stage, essentially it cannot be confined to one radiation field. There's lots of nuances to that, and that's why we use the TNM staging system with small cell lung cancer as well. But because of the differences in these cancers, we do use a little bit of different staging overall. Another part of this that's very, very important is next generation sequencing. And so for all of our patients that are non-small cell patients that have an adenocarcinoma pathology, we're going to send them for next generation sequencing. And the purpose of this is that we're assessing for tumor genomic changes and PD-L1 expression before we initiate therapy, because this gives us guidance onto what the tumor is actually made up of. NGS is molecular testing conducted on these biopsy tissues that gives us a comprehensive molecular profile. And this helps drive the treatment decisions for our anti-cancer therapies. So we'll talk a little bit more when we talk about the different treatments. But it is very important because what we find out from this also gives us a better idea of the patient's prognosis. We might not be able to find anything that's targetable with certain treatments, but we might find things that tell us certain tumor markers that would say the patient is likely to respond to certain medications or unlikely to respond to certain medications. So it's very informative, even if it doesn't give us straightforward answers. So knowledge check number 2. Which of the following are diagnostic procedures for lung cancer? Select all that apply. Screening, imaging, biopsy, or hearing test. So if you said screening, imaging, and biopsy, you are correct. This is just an image here of what NGS testing looks like. What we get here is basically a molecular profile, and these two different pie charts are breaking down. This one on the left is showing somatic driver oncogenes and adenocarcinomas of the lung from former or current smokers. And so there's a smaller percentage there for patients that have an EGFR mutation. And we know that patients that have EGFR mutations can receive targeted therapies. One of the most common ones right now is Tagrisso. These patients tend to have better outcomes with targeted therapy. They feel better on them. And so receiving a molecular report that shows you have some kind of targetable oncogene is kind of viewed as a success for patients because we know that they'll likely have better outcomes and they'll feel better going through treatment. But what we know from this is that never smokers are more likely to have driver oncogenes that are causing their cancer. So it is very common to have patients that have a driver oncogene causing their cancer, and they can present with lung cancer even though they've been a never smoker. So how do we treat lung cancer? Once we get the tissue type and staging is confirmed, patients and families will discuss treatment options with their oncologist. The treatment is determined by evidence-based practice, and our goals are that we're balancing quality and expected duration of life with the patient's goals. So always this is going to be a patient and family-driven discussion. What we can do is provide the information and the guidance, but always it's going to come down to what is the patient's goals and how do they want to feel, where do they want to be. These decisions often involve medical, surgical, and radiation oncology, and then other times we're involving other specialists like palliative care and nutritionists that will come on and kind of help us facilitate care for the patient. About 20% of non-small cell patients are stage 1 or 2 at time of diagnosis and can be treated with surgery or adjuvant therapy, which is chemo or targeted therapy following surgery, and radiation therapy. And radiation therapy we're often using for patients that are unwilling or unable to undergo surgery at this stage. So maybe these patients have an early stage cancer, but they have really poor lung function from bad COPD or something like that. And so removing a part of their lung really isn't much of an option. So we can do surgery on occult non-small cell patients. Stage 0, which is essentially just carcinoma in situ, it's not gone anywhere. Stage 1 or stage 2, and then stage 3A non-small cell lung cancer with or without radiation therapy. Stage 3A non-small cell lung cancer disease presentations can range from resectable tumors with microscopic metastases to the lymph nodes to unresectable bulky disease involving multiple nodal stations. So this is why staging is so important and having a good idea of which lymph nodes are involved. Treatment typically is going to center around immunotherapy with platinum-based chemotherapy prior to surgery. So prior to surgery, treatment received prior to surgery is considered neoadjuvant. And the goals of this chemo and immunotherapy are going to be reduction in tumor size, early eradication of micrometastases, and better tolerability. In regards to this micrometastases, what we know is that we can see on imaging where cancer has manifested But we also know that cancer is kind of dirty, and it can be in teeny tiny cells that haven't actually manifested yet. And so the goal is that we are trying to be as aggressive as possible to match the aggressiveness of the cancer and give patients the best outcome. Adjuvant chemotherapy, again, which is chemo after surgical resection, targeted therapy for patients with EGFR mutated cancers, and immunotherapy for patients whose tumors have at least 1% PD-L1 expression, increase survival. So this is why our next generation sequencing is so important. We want to know these things about why the patient's cancer, or what the patient's cancer is made up of, so that we can make informed treatment decisions. Patients with stages 3B and 3C non-small cell don't benefit from surgery alone and are best managed by chemotherapy and radiation therapy. So if we went back and looked at that chart from earlier, it would tell you what constitutes 3A versus 3B and 3C. This is typically involving concurrent daily radiation and weekly chemo for 6 weeks. So that would look like the patient is coming to see me in clinic once a week, every week for 6 weeks, and then they're getting chemotherapy following that on one day. And throughout this time, they're also receiving radiation therapy Monday through Friday during that 6-week period. Close co-management with medical and radiation oncology teams during this time is very, very important. We work really closely together, managing symptoms and kind of reporting back to one another about how the patient's doing and if there's anything in particular that they need. Following this, most patients are going to undergo systemic consolidation therapy for 1 year with an immunotherapy called durvalumab, and this is an anti-PD-L1 monoclonal antibody. Again, it's important to know the patient's PD-L1 status. We often move forward with durvalumab whether or not they have a greater than 1% PD-L1. But sometimes patients will be on the fence, and it's good to have those numbers so that we can talk to them about it and give them the appropriate guidance. 40% of patients with newly diagnosed non-small cell will have stage 4 disease. The goals of treatment here are to control symptoms and prolong survival, taking into account their history, molecular features, age, comorbidities, and their performance status. Performance status is their functional status, essentially. What are they able to do? Are they young, busy? Do they have kids? Are they working? Are they cooking their own meals? Or are they an elderly patient? Maybe they're already significantly limited mobility. Maybe they're not able to cook for themselves, things like that. First-line treatment consists of either targeted therapy or immunotherapy and chemotherapy, either as combo or alone. So patients can start with targeted therapy if they have an identified driver oncogene, like in that graph that we were looking at, or they can start with a combination of chemo and immunotherapy, which is a combination of 3 separate drugs. And taking into account their medical history, we may or may not use immunotherapy at the same time. Radiation and surgery are typically used for palliation of symptoms. And so we know that with metastatic disease, we're not going to be able to cure their cancer by simply treating it with radiation alone. So we oftentimes try to mitigate the side effects of radiation, and we're using chemo and immunotherapy or targeted therapy. But if patients come in and they have significant tumor burden that's causing them shortness of breath, if they have tumors in their bones, it's very painful, then we can use radiation to treat those. And then oftentimes while we're treating the patient, if they have something called oligoprogression, which is where they'd have the main amount of their cancer controlled or responding to the chemotherapy, but maybe one little piece pop up somewhere else causing a problem, then we'll zap it with radiation and kind of keep going with what we're doing. The goal is that we want to give the patient as much treatment as we can on a certain treatment line before we move on to the next thing. Of the 10, so we're moving on to small cell, excuse me. So those were all non-small cell stages 1 or 0 through 4 is how we're going to stage small cell and how we're going to treat them. We just reviewed. For small cell, again, we're staging these patients with limited or extensive stage. So of the 10 to 15% of patients with small cell, 80 to 85% of them will present with extensive stage disease. This is because small cell lung cancer is very aggressive, so most patients are often presenting with symptoms. By the time they have symptoms, the cancer is usually already progressed past the point of their lungs. Treatment for limited stage disease focuses on chemotherapy and radiation. These patients may choose to undergo something called prophylactic cranial irradiation with the intent of preventing brain metastases, because about 60 to 65% of patients with small cell, limited stage small cell will ultimately end up with brain lesions. First-line treatment for extensive stage disease focuses on combined chemotherapy and immunotherapy. So again, small cell is very aggressive. Patients presenting with extensive stage disease is most common, and our goals here are going to be that we are being as aggressive as possible, but also knowing that extensive stage disease does have a very poor prognosis, and we're trying to kind of mitigate those side effects and make patients feel as best as we can while treating them as best we can. So in general, side effects from certain treatments, so we reviewed surgery for earlier stage cancers. Side effects from surgery are going to include pain, cough, difficulty breathing. This might be after patients have had resections or they've had procedures where we're infiltrating the lung tissue. They can have collapsed lung, fatigue, prolonged recovery, blood clots are all possible. From radiation therapy, the biggest things we're managing are esophagitis, which is irritation of the esophagus. So if you think you're getting radiation to the chest, then your esophagus is certainly kind of targeted here, even if not a direct target. And so patients will get burning and irritation there, and they can have lots of weight loss, difficulty eating. Stomatitis, excuse me, is where you get ulcers in the mouth, mucositis, cough, shortness of breath, skin changes, skin burns, loss of hair, skin changes, again, loss of appetite, fatigue, weakness, and then something more complex that we see is pneumonitis, which is essentially inflammation of the lung tissue, and this commonly occurs shortly following radiation, or if it's going to occur, it's going to happen shortly following radiation. Types of medications that we're going to use to treat lung cancer, we've got chemotherapies, cisplatin, carboplatin. A lot of our metastatic cancer we're going to treat with a platinum-based therapy, and pemetrexed that's down there, and then an immunotherapy, pembrolizumab, would be first-line therapy. The cisplatin or carboplatin and etoposide with the atezolizumab down there is going to be first-line therapy for extensive stage small cell lung cancer. So all of these words, names, they don't mean a whole lot until you apply them to exactly what we're treating. So mostly chemo and immunotherapy, but on the chance that we're finding patients that have a driver oncogene, some of these targeted therapies over here, I've listed next to them the actual driver oncogene that kind of applies. So sotorasib for KRAS mutations, osimertinib or Tagrisso, like I mentioned earlier, for EGFR mutations, selpercatinib for RET mutations. Those are all going to be oral therapies. Up there by the bevacizumab and the ramucirumab, those are IV therapies, as well as the trastuzumab, HER2, that's an IV therapy as well. So kind of combinations. Sometimes we can use oral, sometimes we're using IV, and sometimes we can use them together. Side effects from chemo. I tend to tell patients that there's a whole slew of side effects. Some people will get some of them, some people will get all of them, some people will get none of them. There's not really anything that tells us which, who's going to get what, but we always provide education on what's possible, and we try to mitigate this as best as possible with our the help of our palliative care team and our clinical pharmacists by making nausea plans and things like that. So just like general chemotherapy, nausea, vomiting, appetite, and taste changes, weight loss these patients will experience. Fatigue and weakness are almost across the board, significant experiences for everybody. Some people will have diarrhea, some constipation, and some both. Mucositis, again, which is ulcers inside the mouth, sores in the mouth. Changes to electrolytes, so they might have disturbances in their potassium and magnesium, sodium. Myelosuppression, which is referring to anemia, thrombocytopenia, and neutropenia, which is red blood cells, white blood cells, and platelets. And so those can all be low as a side effect of the chemo. Alopecia, which is hair loss, and then peripheral neuropathy, not entirely exclusive to chemo, but we do see chemo-induced peripheral neuropathy, which is tingling in the fingers and toes. Immunotherapy, while very, very well tolerated, generally does carry some significant side effects, and patients can experience these very significantly. Commonly, patients will have kind of like a dry skin, itching. Sometimes they'll get a rash that's full body and is more of something that needs to be managed medically. Joint pain, diarrhea, thyroid changes, fatigue, and organ toxicity. There's a scale for all of this, and some of them, patients might have all of these things and they're relatively easy managed in what we would consider to be grade 1. And then there's, patients can have grade 2, grade 3, and grade 4. And of course, as we get up in grading, the side effects are more severe and more reasons why we might stop or delay treatment. So knowledge check number 3. Which of the following are treatments for lung cancer? Select all that apply. Surgery, chemotherapy, radiation, immunotherapy, and behavior therapy. So if you said surgery, chemo, radiation, and immunotherapy, you are correct. So supportive care. A lot of what we do for our patients is supportive care. This can sometimes be the most complex part of what we do because everybody's different and everybody experiences different side effects, and the magnitude of these side effects is specific to each patient. So the first thing would be respiratory distress. Again, this can happen from surgery, radiation, just by nature of what the cancer itself is doing. These patients can have airway obstructions or restriction from the cancer. They might have inflammation from treatment, inflammation from radiation treatments, immunotherapy. They could have infection and inflammation, or they could have effusions. An effusion is something where the fluid accumulates between the lining of the lung and the lung itself. So fluid accumulates in the pleural space, and this is called a pleural effusion. What it does is basically pushes up on the lung, and that restricts patients' airway space, and it will make them very short of breath, and it can be painful also. Patients with respiratory distress will present with cough, shortness of breath, pleuritic pain. Again, that's pain related to their lung, kind of on the outside of their lung, and tachycardia, so high heart rate. Supportive measures for these patients, supplemental oxygen, whether in the hospital or we're working to send them home with supplemental oxygen. Of course, when we see them in clinic, if this is new or rapid onset or very severe, then we're thinking, do they need a chest x-ray? Do they need a CT? Is there something that we can do like a thoracentesis where we're going to drain the fluid out of that pleural space so that they can breathe better? Do they need antibiotics? Things like that are where our wheels are kind of turning and thinking this goes beyond just a side effect of their lung cancer and more into the territory of something that's acute and reversible. So we're going to manage these patients with respiratory medications. This might be supportive inhalers. We're going to work very closely with pulmonary doctors when needed, or maybe they already have them, and so we're having them utilize their pulmonologist to help manage these medications. And a lot of times I'll tell patients it's okay to take things over the counter if they have a cold or something like that. But I also like to recommend warm mist humidifiers that kind of help move phlegm that might be thick. They can use an incentive spirometer where we're working on expanding the lungs, or something called a flutter valve where we're working to kind of break up the phlegm in their lungs so they can more easily cough it out. And then, of course, some patients might need pulmonary rehabilitation. And this is the same as like physical rehab, where they go and they work on breathing exercises and things like that. Fatigue. Cancer-related fatigue is prevalent in 75% of patients with metastatic disease. And this can be directly related to treatment or the cancer itself, and it can last for years to months following treatment. So I think we expect that patients that are undergoing active treatment will have a degree of fatigue. Again, it's specific to each patient. Oftentimes it's tied to the amount of chemo or the severity of chemo they're receiving, or other anti-cancer therapies that they're receiving. But also we have patients who don't receive any more treatment, but they still have a prolonged fatigue that's really, really hard to shake. So this could be from the pathology itself or, again, the cancer treatments. These patients might have a worsening performance status, so they might have come in very robust and healthy despite them having lung cancer, but as time goes on, they've lost a lot of weight, they can't get out of bed, they maybe have to take a break from work, they can't interact with their families, things like that. They're tired, they're weak, and then other times they have severe depression. And I think these things go hand in hand, especially when you have very young patients who have families and they have jobs and they're trying to work and care for their families, but also undergoing very aggressive treatment, and their ongoing fatigue and the loss of the things that they were once able to do can really, really weigh heavy on them mentally and emotionally. So supportive measures, we're encouraging them to increase both rest and exercise. I always want my patients to rest, but I also want them to try and get outside and walk, even if it's just for 15 minutes a day. Get some exposure to outside air, sunshine if possible. Seeking companionship and supportive relationships. This is important because a lot of patients don't have companions or supportive relationships, and so we might be connecting them with our cancer support group so that they can meet with social workers and therapists that can talk with them, or they might have support groups that they can meet with for patients that are going through similar experiences. And then, of course, prompt clinical intervention, again, for reversible clinical concerns. So if patients are having severe fatigue, maybe disproportionate for what I would expect, then I'm looking at their labs. I'm trying to see, do they have anemia where I can give them a blood transfusion? Are their electrolytes funky where they could tolerate from some repletion while they're in infusion? Do they just need some IV fluids? Things like that. And then, of course, palliative care involvement. They're going to help us with supportive care for all of the things our patients are experiencing. And sometimes it's a combination of lots of things. We may not be able to pinpoint specifically it's one thing or another. It's just the culmination of everything that's going on. And that can be somewhat complicated because we might be able to mitigate some of the causes, but certainly not all of them at the same time. Other things our patients experience are nausea, vomiting, and weight loss. This might be directly tied to chemotherapy or radiation, especially if it's directed at the GI tract, the liver, or the brain. And then we have anorexia-cachexia syndrome, which is basically where patients have a lot of weight loss and muscle wasting. The presentation is going to be severe weight loss and muscle wasting, electrolyte abnormalities, dehydration. Generally, patients, it's very important for me to know whether or not they're having nausea, vomiting, diarrhea, because those would be the patients that I would anticipate having magnesium deficiencies, which might also contribute to their fatigue. They might be dehydrated and they could have some acute kidney injury and need IV fluids. These patients are also going to have a lot of fatigue and lethargy. So supportive measures for these patients are going to be aggressive antiemetic regimens. We know that some of our chemos carry higher emetogenic potential, and so we anticipate this by sending them home with antiemetics so that they can stay ahead of their nausea. We can come up with a calendar and a plan so that they know when to take what medications. And a lot of times this helps at least keep it at bay or keep it under control. But when it doesn't, we can refer them to nutrition therapy. These nutritionists are going to help us try and keep their weight at a specific amount, because if it gets too low, then we know that our treatments are dangerous for them and we're potentially harming them. I'm always encouraging my patients to adopt a high-fat, high-protein, high-calorie diet. I don't generally recommend them staying away from any foods. You know, if all they can really stomach is chocolate cake, then I certainly want them to eat that if that's what it means that they're going to be able to keep their weight up. Sometimes we do have patients, especially if they have severe esophagitis, that will need a feeding tube placement, and so we can facilitate that. If necessary, we can delay or dose reduce their treatments. And then, of course, for patients that have anything that can be reversed, if we can give them electrolytes, if we can give them fluids, then we're going to certainly try and do that. Sometimes we're giving patients nausea medicine in the clinic or an infusion to try and get them to feel better. A lot of our patients also have pain. This is estimated to occur in 20 to 50% of patients with cancer. Pain management is very highly individualized because everybody has a different tolerance for pain, and everybody has different presentations of their cancer. A lot of people expect that cancer is supposed to be painful, and that's not necessarily true. It's dependent on the location and the size of tumor. And so we know that tumors that are inside the lung are not typically painful, but tumors that are on the lining of the lung or abutting the pleural space can be painful. Tumors that are in the liver capsule can be painful. And of course, tumors that are in patients' bones are very painful. Additionally, it can be not related to the tumor itself, but treatment related. So these patients might have postoperative pain, or they might have post-radiation therapy associated pain. The best thing that we can do is give them supportive care. So we're giving them oral analgesics. We usually start with over-the-counter medications like Tylenol, ibuprofen. We can use lidocaine patches. We're also using non-pharmacologic measures like heating pads, biofreeze, massage therapy, acupuncture. There's all kinds of things, stretching that we can try and do for patients. But of course, when that's not working, then we can use narcotics. And a lot of our patients are on narcotic therapy because we're trying to get them comfortable. There's a lot of, I think, fear with narcotic therapy in cancer patients because patients don't want to become addicted to pain medicine, and I think that's completely warranted and important, and it's important for us to know that as healthcare providers. But I always encourage our patients, generally if you have true pain, the concern for addiction is lower, because what we want to do is make sure that your pain is controlled, and there are certain instances where we know that we might not be able to get rid of this pain completely because we can't get rid of the cancer completely. And so the goal is keeping the patient comfortable. Again, prompt management of acute presentations. When patients come in with new pain, that's usually kind of a trigger sign for me, because it means that there could be new cancer in new places, and we need to look and find where that could be. This is an image just showing you different types of lung cancer pain. It kind of just plays into how different our management can be, because everybody's going to present with different pain based on their side effects, and management of this may or may not be done with over-the-counters, may or may not be done with narcotic medication regimens, and a lot of times we do rely on a lot of other teams, whether it's radiation therapy, palliative medicine, to kind of help us make sure our patients are well cared for. Knowledge check number 4. Which of the following are side effects of cancer therapy that often require supportive care for lung cancer? Select all that apply. Fatigue, nausea, vomiting, weight loss, pain, and tinnitus, which is ringing of the ears. So the answer to this would be fatigue, nausea, vomiting, weight loss, and pain. Notably, tinnitus is a side effect of lung cancer treatments. Specifically, cisplatin is a chemotherapy that we use most commonly for the management of small cell lung cancer. And you can have ringing of your ears from that, but I wouldn't say it typically requires supportive care. We usually stop that medication if patients are having ongoing and persistent ringing of their ears with this. So I want to talk a little bit about some of our specialty supportive care teams because I've mentioned them a lot. They're very, very important in what we do. But palliative care is a medical specialty focused on the management of symptoms to promote quality of life, and it's used through all stages of lung cancer. So I think commonly patients hear palliative care and hospice and they're not quite sure what the differences are. But palliative care we use in conjunction with anti-cancer therapy. So you can be receiving chemotherapy, radiation, what have you, and we're still going to call on palliative care when we need help with managing severe fatigue, nausea, vomiting, pain, depression, anxiety, things like that. Studies show that incorporation of palliative care at the time of diagnosis for metastatic disease improves patient outcomes. And this is received in addition to cancer care. So this is oftentimes our teams are working together. I know in my lung cancer clinic, I'm often working with the nurse practitioner for palliative care, and we'll see patients together. We're doing different things, but at the same time, and both of our outcomes are dependent on one another. Hospice care is care that's provided to both the patient and the family when a patient is considered terminally ill and no longer pursuing anti-cancer therapy. The goals of hospice are to allow patients to die comfortably with necessary support for both patient and family. And hospice is going to involve physicians, nurses, social workers, and therapists that are going to work with the patient either at home or in the facility to kind of facilitate end-of-life care on an as-needed basis. So when we see these patients in clinic, and we recommend hospice, we'll place a hospice referral, and usually hospice will come out to the house, and from there they kind of take over the care. They're managing patients' pain, their shortness of breath, pretty much any type of symptoms that can arise from the progression of their lung cancer and the absence of anti-cancer therapies. There we go. And so this is also a very important aspect of what we do. It doesn't necessarily mean that the patient doesn't have, but weeks or days or something of that nature. It just means that our treatments are no longer, we basically don't have anything else to offer in terms of treatment for anti-cancer therapy, and bringing hospice in is the goal of kind of realigning the ways that we think we treat cancer, reevaluating the patient's care, and focusing on their quality of life. Any questions?
All right, Chaely, that was amazing. There's so much information
so
there.
much information.
So let's see. We'll go ahead and zoom out on the camera. There we go. Thank you. And so one question I meant to ask you at the beginning, but what got you interested in healthcare and cancer specifically? And then what was your career trajectory from the point where you said, hey, I think I might want to do something in healthcare, want to do something in oncology, to the point where you have all those letters by your name? And how did you get there?
So I've been exposed to medicine and healthcare for my whole life. And so I always knew I wanted to do something in medicine or healthcare. I just didn't really know what. And so when I went to school, I was kind of feeling it out, and I chose nursing, and so I got my BSN from Appalachian State, and I didn't know what I wanted to do when I got out of school. I just kind of cast the net, and I started in med-surg, and the floor that I wound up on was oncology and orthopedics, which is kind of like a funky combination to me still. But so we saw patients that had knee replacements and things like that, but also would be chemotherapy starts in the hospital. And then from there I moved to critical care. So I was working in a med-surg ICU and kind of saw the whole gamut. We would see some lung cancer patients and just cancers of all kinds, but one of my specific memories of a patient was a lung cancer patient that I felt like I had a really nice connection with. From there, I went to school. I knew I wanted to do advanced practice, and so I went to school at UNC, and at the time, I wanted to do palliative care because working in the ICU, we did a lot of palliative care and comfort care. And so that's why I did the oncology focus, and I was really interested in palliative care, and we had to do rotations in oncology to get the certificate. And when it came time to do my thesis, I had a family friend who had just been diagnosed with metastatic lung cancer, and she is a never smoker. And so it was very, very interesting to me because I didn't know anything about that.
Yeah.
She was a never smoker and diagnosed with diffusely metastatic lung cancer and started a clinical trial, which at the time was phase 1, and now this is standard of care drug. So this is 5 years later. But anyways, that kind of got my wheels turning about lung cancer. So when it came time to write my thesis, I wrote it about palliative care in lung cancer. And how do we utilize that, and how can we make it better for patients? And then kind of the rest is history. I interviewed for a job with Thoracic, and
Great.
here I am.
Great. Well, we're very glad that you did.
Thank you.
This has been very informative. A couple of other questions. I know sometimes for folks who are unfamiliar with cancer, when you talk about metastatic cancer or so let's say lung cancer or cancer that's metastasized to the lungs, somebody might think, well, wait a minute, if it metastasized to the lungs, wouldn't that be lung cancer?
Right.
And yet it might not be. It might be another type of cancer that is. Can you explain that?
Yeah, so a lot of times we'll have patients that have lung cancer that's metastasized to the brain. So if you were to go take out that tumor in the brain, it would read adenocarcinoma of the lung.
Gotcha.
It's going to match what's inside the lung. Whereas if you had a patient with breast cancer and they had a new lung nodule and you went and took out that lung nodule and looked at it, it would read breast cancer.
Gotcha.
And so it's cancer that has the same pathology of the original diagnosis, and it's moved away from that. So patients that have liver metastases, it's not liver cancer, it's lung cancer in the liver.
Thank you. I think that can be confusing
Certainly.
when folks are
Yeah.
first learning about this. One more brief question. I've got a ton of them, but I know people don't want to be here all day. Multidisciplinary team. This is such an important aspect of healthcare, is that you don't work in isolation. Talk for just a moment about how the others you work with. I know you touched on that at multiple points during your talk, but who are some of the other people who you interact with, and how do you interact with them?
I'm glad that you asked, because I maybe didn't give credit where credit's due. So we have an MTOP group, which is our medical thoracic oncology program, and we have a tumor board once a week. And this tumor board encompasses surg-onc, like thoracic surgeons, radiation oncology, medical oncology, pathology, and sometimes it's physicians from other specialties. So like we might have a breast cancer provider that comes in and says, I've got this patient. They want to present this patient. They have a patient with certain features, and they don't quite know what to do with this patient outside of their breast cancer world. And so everybody kind of puts their heads together, and we'll pull up the images with I can't even think of the word, people that read scans.
Right.
Radiology.
The radiologists. Sure.
We'll pull up radiologies there. So the PET team is there, the CT team is there, brain MRI, they can all be read at the same time, and everyone's kind of taking this patient. Somebody presents the patient. They have their clinical question, as in like maybe what do we think of this as the team? And literally every specialty will kind of weigh in and say, this is the current diagnosis based off of pathology. Medical oncology might say, this is how we would treat it. And surgery might say, we can take it out. So everybody's kind of putting their 2 cents in. And from there, the patient has a plan, essentially, and a team to kind of start with. And then once, say, like if the patient goes to surgery, they'll have surgery first. Surgery then communicates with us, sends the patient to us. We treat them with chemo, and then we're communicating with them back and forth to make sure the patient has the right follow-up.
Right.
And so that's our MTOP team. So there's a lot of people. And then we have, like I was mentioning, palliative care, who's supportive and kind of comes on kind of during treatment or even sometimes after to help us manage some of the ongoing things related to treatment and related to cancer.
Great. Thank you.
Yeah.
That's so important. And I you talked about the relationships with the patients being primary at the introduction, but I imagine the relationships that you form with the other healthcare providers.
We work
means
closely
a lot.
together. It's good to have good teamwork.
All right. Well, let's go ahead and thank you, of
Yeah,
course.
thank you.
You've got references here. Thank you for that. And then I want to thank the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. Each one of them is a part of our multidisciplinary team and all the hard work that they do. We want to thank the North Carolina Community College system for this collaboration and all of the community colleges, amazing 58 community college
Wow.
system, third largest in the country, for their participation.